Good evening. Jagsonpal Pharmaceuticals Limited Pharma Division would like to extend warm welcome to the experts and attendees for joining this web series Expert Speaks with the theme Women's Health is Nation's Strength, organized by Dr. Archana Verma with Haridwar Obs and Gynae Societies and academic partner Jagsonpal Pharmaceuticals Limited, makers of Divatrone, Maintain and Divagest. We would like to present Divatrone 10 milligram tablet, fully indigenized, micronized dydrogesterone, the only brand having the 36 months of shelf life. We present to you a range of natural micronized progesterones as Divagest. Through this web series, Jagsonpal would like to thank the experts and attendees for joining us today. For today's web series, Expert Speaks, I welcome Dr. Rashmi Sharma. She is an Obs and Gynae at Shiv Krishna Hospital, Ghaziabad. Presently, she holds the office of Joint Secretary in West UP ISOPARB and has received IMA Presidential Appreciation Award in 2023. Ma'am, please start this session.
Myself, Dr. Rashmi. Good evening, everyone. You all are welcome for today's session. आइए कुछ आशा की बात करें. मुस्कुराओ तब भी जब जिंदगी उदास होने का मौका दे. जिंदगी को भी तो मालूम चले कि हम सिर्फ थके हैं, हारे नहीं. So next in series of Expert Speaks, it is an initiative by Dr. Archana Verma. So before starting our session, let's begin with the prayer for God Almighty, the goddess of knowledge and wisdom, Ma Saraswati. So let's close our eye and chant Saraswati mantra. Om Namo Saraswati Namo Namaha.
Ya Shubhravasravruta Ya Veena Varadanda Vanditakara Ya Shveta Padmasana Ya Brahmachyuta Shankara Prabhutibhi Devai Sada Vandita Sa Maa Patu Saraswati Bhagavati Nishesha Jadyapaha Shuklam Brahma Vicharasara Parama Adyam Jagat Vyapinim Veena Pustakadharinim Abhayadam Jadyandhakarapaha.
Thank you, Dr. Deepika. Now I invite Dr. Archana Verma ma'am to say something about this session and Expert Speaks.
Thank you, Rashmi. I want to work mainly for women health. This is my motto, and I know without team this is impossible job. So this Expert Speak series was made mainly to make the woman more healthier, because we all know that making women health always give strength to the nation. And this a problem, like whenever there is a today's talk, and we have invited a great speaker, Dr. Muralidhar Pai sir, and our chief guest, Dr. Kawita Bapat. Dr. Kawita Bapat is a very well-known vaginal surgeon of this from Indore, Madhya Pradesh. And she has worked a lot in the field of vaginal hysterectomies, also one step, and very good friend also. And today she will join late because she is busy somewhere. And we are very thankful to her to accept our invitation. And this, that today's threat of harm. Nobody in this world want any harm. And if somebody is threatening them, so they all need to work for that. So avoid that, prevent that, and how to cope up with that threat. So if we have the experience or the tips or the management tips for that any threat, any sort of any threat, whether it is election, whether it is a disease, and whether it is competition, anything. anything where you are feeling some survival of presence or survival of your as a life matters. So for that we need to follow certain goals, because these goals, keeping goals always make you feel safer and make your achievement easier, because this is a very powerful tool. Anybody should have certain goals in life, what you want to do, what this, how this webinar is going to help our academicians, our FOGSians, our gynecologist friends and patients also. So for this goal setting and better management, we need to have certain motivating, inspiring and feeling to learn. And this, even learning is a great thing, where we should always should keep our eyes and ear open to learn and improve our skills. And I always say that breaking down goals into smaller sub goals is also very, very important, so that you don't feel the overwhelm or the burden, too much burden on yourself to make that goal possible. And this always gives your good way and time to jump to another goal one by one, like step up policy. You should, one cannot do all work in one day. So one by one we can tackle the problems, and we can talk to experts. It helps really, and it gives a feeling of belonging also. Like if we are a team and we are working together for the women's health, this is something very, very important. And one should work smartly. I always say smart management is a real management. S stand for I want to tell everybody that this is my own way of doing work. So S is a specific, always be specific. You must know, like if you are going to tackle a plan or a patient also, be specific. You one cannot be like a lower court and high court and supreme court at one place only. So whatever you are doing, do your best, and never bother and never feel shameful to ask others. And the goal should be measurable also. Okay, how much work you can do and how are you going to do, and it should be achievable and relevant also, and time bound. If it is there, then we can do much better. Just suppose threatened abortion. If your patient comes and you are waiting too long to diagnose or to advise certain things, or just waiting, okay, we have counseled or we have not given certain medicine, how much to give and how to give, and this always there is a clinical dilemma. So because sometimes we do the things, and sometimes we don't do at all. So all these things matters. For that, today I want to thank all our speakers and who will tackle this problem. And Dr. Paridhi will be talking on post abortion crisis, which is a very, very important thing to tackle, and we should not be judgmental. One thing we all should know that if whatever you are doing, do considerately, passionately, but never be judgmental. So I hand over to Rashmi to take the program further, and thank you very much.
Thank you, ma'am. Thank you for your pearls of wisdom, ma'am. So let's start today's session. Next in, experts speak on recurrent pregnancy loss. As we all know, this topic is very much relevant in today's scenario. As the age of marriage is increasing, the environmental factors are changing and food habits are changing day by day. So patients are also very much aware about it and gets a lot more of psychological trauma with each pregnancy loss. There is no good quality evidence about this. Either people are doing so much about it or doing nothing about it. So there is lot more of controversies. So today we are not going to talk much about the theory part, but some practical take-home points. Those are beneficial in our day-to-day practices. So there is a beautiful saying by Albert Einstein about the doctors treating the patients with RPL. The more I learn, the more I realize how much I don't know. So we should know something, and let's know something about it so we can treat our patients well. So let's welcome our chairperson for the first session, Dr. Manisha Gupta ma'am. She is the professor HOD Santosh University, and she has got 25 years of teaching and clinical experience in gynae. And she has special interest in adolescent health, high-risk pregnancy oncology, and she's a recipient of FICOG Award and Dr. Manjula Memorial Award for free service in Obs and Gynae.
Thank you, Rashmi.
Yes,
Thank you,
ma'am.
Dr. Archana Verma, for inviting me and chairing to chair the session. Welcome, sir. I take pleasure in inviting Professor Dr. Muralidhar Pai, who is a dean of Sikkim Manipal Institute of Medical Sciences, Sikkim, and he is a professor in Obs and Gynae. He has many academic accolades to his credit, like he is an academician and working with 36 years of experience, 20 awards, many fellowships, and many publications, both as papers and textbooks. And he has been here to deliver many guest lectures, and we are very fortunate to have him here. Thank you, sir, for joining us. Now, without any delay, I would like you to start your talk.
Thank you very much. I thank Dr. Archana Verma ma'am for always keeping me in her mind for all her webinars and her conferences. Thanks once again. It's easier for me to be now participating more in webinar, though COVID is far behind us. I'm in such a location that I'm unable to move freely. So I'll be happy to participate in webinars. One correction there, I was told to talk on threatened abortion actually. Even the title reads face the threat and not recurrent abortion. So, I mean, I would have spoken on recurrent abortion, but today I was specifically
Yes,
asked.
it was threatened abortion only, sir.
Yeah, okay. So I'll be speaking on threatened abortion. Facing the threat, the best way to face the threat is just face it because there is no other go. And that's how we will find the solution and manage it successfully. So the scheme of my presentation for today would be, first I'll talk about the general aspects, and then I will move on to etiopathogenesis, and then investigations, and finally the management. First, let us look at the general aspects. Threatened abortion is one of the most difficult areas in reproductive medicine because the etiology is often unknown or unclear. And there are very few evidence-based diagnostic and treatment strategies that are available. So we have to play within those limitations. As far as definition is concerned, it is vaginal bleeding before 28 weeks in Indian setup, whereas according to WHO and rest of the world, it is 20 weeks. Because in India, up to 28 weeks, we consider pregnancy as unviable. Only after 28 weeks, we consider it as viable. I totally agree with this concept actually, because if you deliver the babies too prematurely, it will have its own problems. Anyway, today I'm not going to debate that issue. Vaginal bleeding before 28 weeks in Indian scenario with a closed os, that is very important. There is nothing on the way or in the cervical canal. Without passage of products of conception and without evidence of an embryonic or fetal demise. So it's very, very clear. The most important thing here is that the baby is alive. Because if the baby is dead, sometimes it may be, pregnancy may be continued for some time and os may be closed. That is considered as missed abortion, not threatened abortion. To qualify to be threatened abortion, the fetus has to be alive. The prevalence, nearly 25% of pregnant women have some degree of vaginal bleeding during the first 2 trimesters. So it is actually very common, the threatened abortion, is not uncommon, at least I can see. And about 50% of these progress to loss of the pregnancy. That means around 12% eventually succumb to this threatened abortion, and we won't be able to help these women much. It's only in the other 12% we can think of something. This has to be clearly understood. Otherwise, we'll be spending a lot of money, energy, and psychological, harm to the patient. Etiopathogenesis, as I said, it is extremely difficult situation to pinpoint at a particular cause of threatened abortion. It is widely accepted that 50% of cases of spontaneous threatened abortion that end up in abortion cannot be prevented or treated because they may be due to chromosomal abnormalities. This is a very, very important slide. If there is a fatal chromosomal abnormality, no matter what you do, no matter how much of any drug that you give in kilograms also, this pregnancy is not going to continue. So we have to be aware of this problem. Otherwise, we'll be again causing trauma on the patient, psychological trauma. What are these chromosomal abnormalities? There are significant proportion of pregnancy loss are due to either numerical, that is aneuploidy or mosaicism, or structural chromosomal abnormalities, which can be translocation, inversion, deletion, or fragile sites. So it is important whenever a patient comes with the symptoms of threatened abortion, the first thing that we have to do is rule out chromosomal abnormalities, especially the fatal ones. So here comes the role of the fetal medicine specialist, because it will save not only our efforts, our energy, the money, and everything. So we have to rule out chromosomal abnormalities first whenever a patient of threatened abortion comes. The increased risk is seen in first-degree relatives, may be related to shared HLA types, coagulation defects, immune dysfunction, or other undefined heritable factors. So when you ask the history regarding threatened abortion, it is important to ask this history of consanguinity, because we know that most of the chromosomal abnormalities are shared among the relatives. And if there are unbalanced reciprocations or translocations, then there can be abortions. The risk of abortion is somewhat like this. Carriers of 22 to 22 translocation will always miscarry no matter what you do. Carriers of 13 to 14 translocations have 25% risk of abortion. For euploid, that means normal chromosomal makeup abortions, maternal and paternal factors play a more significant role. So once you rule out chromosomal problems in the fetus, then only you turn your attention towards maternal and paternal factors. Let us look at what are they. 3 essential elements are important for successful pregnancy. Number 1, a viable embryo. There should not be any anomalies in this particular embryo in terms of chromosomal, genetic, or otherwise. Then the receptive uterus. Just if the baby is fine, that's not enough. The uterus also should be very receptive. It should keep the baby for 9 months. Otherwise, there can be problems. Then, of course, behind both of them, the baby and the uterus, the maternal immune tolerance is very important, because 50% of the baby is a foreign antigen. It is actually one of the wonders of the world that the mother does not reject the baby in spite carrying 50% of foreign antigen. So Ultimately, it is immune tolerance that is very, very important after having a viable baby and a good uterus. So what is this immunology all about? The old concept was that pregnancy is a state of systemic immunosuppression. That means mother does not react to the foreign antigen. But the new concept is that pregnancy is a state of dramatic immunomodulation. There is no suppression as such, because if there is immune suppression, the mother will develop so many other problems. So it's not total suppression of her immunological system, but it is a modulation of the immunological system. So the immunological factors which play a role are autoimmune factors. In fact, pregnant or not, women are more susceptible to autoimmune diseases rather than men, due to effects of reproductive hormones on cell-mediated immunity. And it's not something surprising. It is the progesterone and the estrogen. These are the reproductive hormones. They have an effect on the cell-mediated immunity. So let us look at these hormonal or natural immune modulators. I am explaining in this detail because when you talk about the treatment of threatened abortion, understanding of this is very, very important. Otherwise, it becomes like an empirical treatment. Progesterone promotes Th2 type of response. There is Th1 and Th2 type of response. Th2 is facilitatory. Th1 is detrimental type of response. Estrogen also regulates, but it downregulates the delayed type of hypersensitivity reactions. Prolactin also has a role. It stimulates both cell-mediated and hormonal immune responsiveness. So all the three hormones, the reproductive hormones, are very, very important in the successful continuation of a pregnancy. So progesterone has got hormonal actions as well as non-hormonal actions. The hormonal actions are mainly, it stimulates growth of the uterus and stabilizes the endometrium. All of us know that basic menstrual cycle. Initially, it is estrogen that makes it the proliferative endometrium, but it is the progesterone which makes it secretory endometrium, literally a bed for the incoming baby. It also maintains uterine quiescence. The uterus has to be quiet for 9 months. Only towards the end of 9 months will there be alteration in the estrogen to progesterone ratio in favor of estrogen. Only then will there be triggering of the labor pain. So for 9 months, it is progesterone which is maintaining the uterine quiescence. It also inhibits myometrial contractions. Of course, these two actions are same. Because it suppresses the myometrial contractions, it keeps the uterus quiet and holds on to the baby inside the uterus. There is a secretory transformation that increases the vascularity of the endometrium. So it's not only just preparing the bed, but it also keeps on supplying to the fetus through its vascular transformation. So these are some of the hormonal actions of the progesterone. Then there are non-hormonal actions of the progesterone, and they are immune modulation. I was just explaining that few slides earlier. So it has got an immunomodulatory effect in that it favors shift of Th1 to Th2 balance towards Th2 type. That's what I told you. Th2 is a facilitatory type of reaction. It modulates chemokines transcription factor, and also it inhibits tissue rejection and protects the conceptus. So in addition to its hormonal actions, it also has a major role in the immunomodulation. It is a best uterine relaxant, which has already been seen. So it blocks oxytocin effect of PGF2 alpha and alpha adrenergic stimulation. It reduces contractility and it promotes the myometrial relaxation. So there is something called progesterone-induced blocking factor. So if progesterone is lacking, So this blocking factor also will be lacking. What is the role of this progesterone-induced blocking factor? It prevents inflammatory reactions by blocking Th1 cytokines. So that's how it converts Th1 reaction to Th2 reaction, by blocking the Th1 cytokines. It prevents NK cell degranulation, and it increases non-toxic blocking antibodies. By this, it will have a facilitatory role. If there is progesterone deficiency, on the other hand, it destabilizes the endometrium due to increased pro-inflammatory interleukins, that is IL-8, cyclooxygenase 2, and monocyte chemoattractant protein 1. So you don't have to remember all this. You can simply remember progesterone has got a favorable action in terms of immunomodulation. It converts Th1 type of reaction to Th2 type of reaction by several mechanisms. Progesterone deficiency, hence I can safely say, will give rise to characteristic inflammatory response. Now, all the diseases are explained in terms of inflammatory reaction. Now, here also in pregnancy, if there is a rejection, it is due to a low-lying inflammatory response. So, as a result of this inflammatory response, there is a prostaglandin release, which will make the uterus contract. And of course, when the uterus contracts, the product of conception is thrown out. There is a cellular immune system activation. So that again is detrimental to the continuation of the fetal life. And there is increased blood vessel permeability, leading on to what is called subchorionic hemorrhage. And that itself, when it increases, the baby will automatically lose its blood supply, and then it will die. And once the baby dies, it is rejected. So this has to be understood before we embark on managing a case of threatened abortion or a recurrent abortion as well. So if I have to summarize at this juncture, a successful pregnancy has a beautiful balance between the rejection type of reaction to the facilitated type of reaction. In fact, you can say there is a favoritism to Th2 type of reaction. Whereas in a case of pregnancy loss, there is more of rejection type of reaction. It is heavier, so that will give rise to pregnancy loss or miscarriage or abortion. After understanding this immunological causes, let us now look at the other maternal causes. So first we looked at the chromosomal problems where we cannot do much. Only we can detect, counsel the patient, and say, hope for the best. Because one good thing about chromosomal abnormality is that it does not recur. It recurs in less than 3%. For a single or a stray abortion, if it is 50, even up to sometimes 70% a cause, whereas as far as recurrent abortion is concerned, the chromosomal abnormality is the cause in less than 3%. I'm repeating this. So in a way, if a person has chromosomal abnormality in one pregnancy, we can safely tell her she may not have that in the next pregnancy. So her quota of chromosomal problem is over. So that is exactly why whenever a patient with threatened abortion comes, first thing we have to rule out is a chromosomal abnormality, because there we can stop the treatment depending upon, of course, there are some chromosomal abnormalities which are compatible with life and they can be continued. So today it is beyond the scope of the talk. I'm not going to elaborate that. But however, if the fetal medicine specialist says this chromosomal abnormality is not viable, it's not worth continuation, then you can actually reduce the psychological stress on the mother as well as on the family by saying, let this pregnancy go. She can have a better pregnancy in the next time. After that, the immunological problems. I'm going to elaborate a little more what are those later, but we understood that how hormones play an important role in the immunological modulation. Now, coming to the maternal causes, after the immunological factors, it is the autoimmune problems which are mainly responsible for a pregnancy loss, whether it is a single pregnancy loss or whether it is a recurrent pregnancy loss. And they can be seen in 5 to 15% of the cases. And in that, the main immunological problem or autoimmune problem is antiphospholipid syndrome, because it is the only autoimmune condition in which pregnancy loss is a diagnostic criterion for the disease. Whereas other autoimmune problems, for example, lupus or even ANA rise, pregnancy loss is not the diagnostic criterion. Pregnancy loss may happen, but that is not the main diagnostic criterion. So antiphospholipid syndrome is one of the leading causes of autoimmune causes of pregnancy loss. In that, only anti-cardiolipin antibodies and lupus anticoagulant have been clearly associated with pregnancy loss. So there are several types of antiphospholipid antibodies. In that, ACL and LA are connected with the pregnancy loss. What is the mechanism of action? The old concept was that they cause thrombosis, and that is the mechanism by which they cause pregnancy loss. But this is only after the implantation is complete. That means pregnancy successfully gets implanted, but then there will be thrombosis. However, the new concept is that in these patients, these anti-cardiolipin antibodies, they have a direct adverse effect on implantation as well. That is, they alter the decidual cell differentiation. They inhibit HCG production, which is very important to support the pregnancy. And they inhibit trophoblast invasion and fusion. So we all know that trophoblastic invasion is a very important event in the modulation of the vessels. Otherwise, there can be problem of preeclampsia. Finally, it activates the component cascade as well. What about anti-nuclear antibodies? Now, there's big controversy with regards to anti-nuclear antibodies. Many believe in this and they start treating also, and many are still skeptical about it. If at all you do, the more specific autoantibodies are APL, anti-double-stranded DNA, anti-Rho SSA, or anti-La SSB antibodies. But what is more important here to note is that the low titers, that is less than 1:80, were not associated with, while higher titers 1:160, they had significant association with the pregnancy loss. Some more research in this direction is required and it is going on. Pregnancy outcome of women with and without ANA is the same as for this particular paper, which is an old one. But more recently, ANA test is a potential prognostic tool for recurrent pregnancy loss, which merits further research as per this particular article. But available data do not support testing women with threatened abortion for ANA. If it is recurrent abortion, then yes, but it is one stray threatened abortion. Doing anti-nuclear antibodies is unnecessary, expensive, and uncalled for. Other maternal causes are anatomic causes. This is a traditional way of thinking whether it is a recurrent pregnancy loss or a threatened abortion, because ultimately anatomic problems can give rise to bleeding. If you remember the definition, it is vaginal bleeding with a live fetus there. Okay. So what are these anatomical causes? It could be implantation on a avascular septum. So pregnancy has not taken off well, so there will be bleeding. Most common anomaly associated with, in fact, recurrent pregnancy loss, not only threatened abortion, but if you don't correct this, the lady is going to have abortion every time she becomes pregnant. And it has got the poorest outcome. Longer the septum, worse is the outcome. And of course, Definitely these days, nobody will leave them alone. With so much of diagnostic and therapeutic instrumentation available, definitely somebody would remove this septum. There is increased inflammation or reduction in the sensitivity to steroid hormones. That is also a part of the anatomic cause. Then there is impaired uterine distension. So pregnancy cannot grow properly. So it will land up with first threatened abortion and finally it may abort also. Submucous fibroid. It is said in infertility lectures and everywhere that up to 4 to 5 centimeters you can ignore and go ahead with the IVF or implantation of pregnancy. Yes, it is true. But unfortunately, if the implantation occurs at the site of fibroid, so this placentation is not good anchoring. So these are the patients who will have some amount of bleeding. And if they are fortunate, they will continue with the pregnancy. But unfortunate, they can abort as well. It is because of poor endometrial receptivity of decidua overlaying the myoma. There is also degeneration with increasing cytokine production in this area. The most common and popular and well-known cause of abortion or threatened abortion, especially in the second trimester, is cervical insufficiency. Thankfully, this can be tackled by a proper cerclage in selected cases. The cause of recurrent mid-trimester but not early pregnancy loss is definitely due to this anatomical problem. So if there is bleeding in the early pregnancy, don't suspect cervical insufficiency, though it may be there in terms of ultrasonic picture. Defective endometrial receptivity, it is more for a implantation problems and recurrent pregnancy loss rather than one stray threatened abortion. However, that could be the first pregnancy in the series of recurrent abortions you may be dealing with. After anatomic, it is hormonal. We have understood a little bit about the hormonal, the role of hormones in the immunomodulation. Here, it is a different kind of role, that is luteal phase deficiency. We all know that till the placenta takes over, it is the hormone luteal, corpus luteum is the one which produces progesterone that is going to support the pregnancy under the influence of the LH. Whereas once the placenta is formed, then the HCG comes and that will take care of everything. Then it could be uncontrolled diabetes and thyroid disease. We all know that high sugars in the first trimester can give rise to lethal anomalies, and that may be the cause of threatened abortion. And even thyroid disease, both hyper as well as hypothyroidism can cause this kind of a situation. PCOS is known to cause first trimester abortions, so also hyperprolactinemia. I'm going to talk a little more later. As far as LPD is concerned, it is seen in 35% of miscarriages, especially the recurrent miscarriages. They have early loss before the fetal pulsations. As I said, till the placenta is well formed, that is early days, 9 weeks, 10 weeks, and before that, it is a corpus luteum which has to support the pregnancy. So if there is a problem, then there will be an early loss before the baby is actually seen properly. What are the causes? It may be because the defect in the follicular phase itself, not just the luteal phase. The follicle may not have been developed well. So it could be due to decreased FSH. So that's why in patients where they have undergone infertility treatment, a proper FSH stimulation is required. It could be due to abnormal pattern of LH secretion after the ovulation. And then it may be because the primary defect in the corpus luteum, though FSH, LH are doing its job, corpus luteum is not producing progesterone enough. And finally, even though all of them are fine, FSH, LH, progesterone, the endometrium may be not responding properly to the progesterone. So all of them are implicated in this. But the biggest problem with LPD is its diagnosis. the old method of diagnosis, that is endometrial sampling, is given up because we don't want to disturb a by chance pregnancy. The other method is estimating progesterone. That itself is so erroneous. People say day 23 progesterone can be estimated, but that is very, very difficult to interpret. So LPD as a cause remains controversial as to whether such a defect really exists and is related to miscarriage. And there is no consensus on the best method of diagnosis of treatment or treatment. So we will leave it at that for this juncture. As far as PCOS is concerned, in addition to being endocrine abnormality, abortion may be related to obesity. We know that 2/3 of PCOS patients are obese, and good number of them, at least 1/3 to 50% of them, will have insulin resistance. So both may be responsible for abortion. Women with RPL have higher prevalence of insulin resistance than others. Treatment of insulin resistance with metformin was associated with a reduction in pregnancy loss. That's why it is advised, if you used metformin for induction of ovulation, it makes sense to continue metformin even in the first trimester of pregnancy because it is not at all teratogenic. Maybe after that, once you get rid of this fear of abortion, you can discontinue metformin only to restart should she have insulin resistance continued and develop gestational diabetes in the second or third trimester. The thyroid diseases and diabetes, as I mentioned earlier, can also cause threatened abortion or recurrent abortion if it is poorly controlled. So that's why a good control before she conceives, which this comes under the pre-pregnancy counseling. The thyroid should be, when you do TSH anytime, it should be less than 2.5 before pregnancy. And diabetes, as far as we all know, that HbA1c should be less than 5.9 ideally to prescribe pregnancy. An increased rate of fetal loss is seen in women with high serum thyroid antibody concentrations. As far as hyperprolactinemia is concerned, as I told you earlier, it has a major role in the immunomodulation. The prolactin levels during early pregnancy were significantly higher in women who miscarried. Treatment to lower prolactin concentration was associated with higher rate of successful pregnancies. So 86% versus 52%. So continuing with the maternal causes, it could be autoimmune, hemophilias, fibrinolytic factors. But the problem with these three is that very, very difficult to ascertain, and it is not done as a routine. It is done only in the research setup. So I do not really want any one of you to do these investigations, especially in a case of threatened abortion. The others, or what we say unexplained, comes to around 50% of the causes of threatened abortion, which is very, very difficult to ascertain, very, very difficult to prove, and as well as treat. What are they? Teratogens and infections. Well, in a single abortion, when it is happening, infections have got a major role, but they do not have a role in a recurrent abortion. Same is the case of teratogens, because it is highly unlikely that a lady will have the same teratogens unless it is a particular working environment, unlikely to have recurrent abortions. But as far as single threatened abortion is concerned, we have to really explore the possibility of her taking a teratogenic drug or a food or any other substance. Same goes with the infections. Sometimes rubella infections in the first trimester or any high degree fever due to any infection can give rise to abortion. Extremes of weight. Any girl or lady less than 40 kg of weight or overweight, that is more than 35 BMI. So they can have abortions. Now, these are some of the things which are highly debatable: the tobacco products, alcohol, illicit drugs, coffee, tea, papaya. There are so many things which people think that they can be abortifacients. It is wiser to actually avoid them, whether they are really implicated or not. Folic acid deficiency. Definitely, we know that this causes neural tubal defects. Sometimes these neural tubal defects can be very fatal and the baby may die in the uterus. But before that, it can cause some amount of bleeding and threatened abortion. Increasing maternal as well as paternal age. So I've highlighted paternal age. It's not only maternal age, though men can produce sperms even at the age of 80, 90, but those are not very good gametes. And these are the ones which will cause a lot of defects in the zygote, and that will be the cause of threatened abortion. Finally, it is subchorionic hemorrhage. As I told you, if there is leakage through the endometrial vessels, there can be subchorionic hemorrhage, and that will hamper the blood supply to the fetus. And depending upon the amount of subchorionic hemorrhage, you can predict also whether this pregnancy is going to go well or it's going to get aborted. I'm going to talk about all those predictive factors little later in the talk. The stress, whether it is physical stress in terms of coital activity or otherwise, and then psychological stress, they all have a small role in the abortion and definitely in threatened abortion. So the theory is that they promote abortion through psychoneuroimmunological pathway, whatever it means. I really cannot explain that more than this, saying this word. It interferes with normal function of immune system. Probably that's easier to understand. And it increases NK cells that promote Th1 reaction. I am mentioning Th1 reaction maybe a third or fourth time. So this is because of the stress which increases the NK cells. Now, to summarize all this, I can say the intrauterine stage of a fetus is in three parts. One is pre-embryonic, which is up to 4 weeks when there is only zygotes. I mean, before zygote, there's only gametes. And then there is embryonic period, early embryonic, I can say 5 to 9 weeks. And then comes the fetal period, which is after 10 weeks. So in the first two periods, it is mainly chromosomal factors in that genetic factors. And later, or overlapping with the embryonic period, it is autoimmune, thrombotic, anatomic, and all other factors that will be responsible. So epidemiologically, threatened abortion can occur in any pregnancy, regardless of maternal age, race, comorbidities, lifestyle, or socioeconomic status. So nobody is actually immune to threatened abortion. As I said, if you remember the very first slide, almost 50 to 60% of the pregnancies can have some amount of bleeding or cramping. In that, of course, 25% will qualify for threatened abortion. In that, 12% may go for actual abortion. Past history of bleeding in the first trimester increases her risk for bleeding in the first trimester of subsequent pregnancies. Maybe there is something which is underlying cause, maybe a septate uterus or some other kind of uterine anomaly, or some amount of subtle chromosomal problems in her. So that's why the chance increases. These are the patients who are heading towards recurrent pregnancy loss. What is a clinical presentation? Of course, from slide 1, I have been telling it is vaginal spotting or bleeding. It is the most important single presentation in the presence of live fetus, of course, which will be ascertained later. In the second trimester, maybe you can even see or feel the fetal movements and you can listen to fetal heart rate. But in the first trimester, unless you do the ultrasound, you cannot make out the fetal pulsations. It is the most predictive risk factor for pregnancy loss. There should be bleeding, not just some pain. However, abdominal cramping, pelvic pain, pelvic pressure, and or back pain can also be there. Sometimes these may precede bleeding. Sometimes these may be seen after the bleeding. The risk of spontaneous abortion in a patient with threatened abortion is less if the fetal cardiac activity is present and if it is robust. I'm going to elaborate on how much it should be and all that. What are the complications of threatened abortion? Why are we so much worried about threatened abortion? Especially in those patients where we feel that continuation is possible. They may later in pregnancy come with again threatened preterm labor or a full-fledged preterm labor. They can develop hypertensive disorders because if APLA is the cause of their abortion, threatened abortion, these are the patients who are going to come with hypertensive disorders. The same category will also have FGR. In fact, APLA syndrome will have a spectrum of problems starting from threatened abortion to preterm labor, hypertensive disorder, and FGR. They are all the rays of the same spectrum. And APH, especially if the threatened abortion was due to low-lying placenta in the first trimester or second trimester, in the third trimester, if the placenta does not move away, or if the uterus, the differential growth of the uterus does not help the placental being previa, then APH is seen. And obviously, when there is APH, these are the high-risk patients for PPH as well. So, threatened abortion diagnosis is very important because there can be other problems. So, how to investigate them? Of course, for anything, evaluation includes history as the first step. Here we have to take detailed menstrual cycles, breast secretions, which will talk about hyperprolactinemia. Menstrual cycles talk about the possibility of PCOS in her, or hyperprolactinemia, or thyroid disorders, or even sometimes, irregular cycles means that this patient is more likely to have problems of implantation as well. So PCOS and hyperprolactinemia can be easily deduced by asking this history. Age of the patient and characters, like whether the pregnancy loss was early in the past or late, that will tell us about whether it was due to chromosomal problems or a hormonal problem. Late means anatomical or immunological problem, but there can be significant overlap. The congenital or karyotype abnormalities can be made out. It is if there's a history of inheritance. Pulsations seen or not seen is very important, because if it is not seen, that means it's a chromosomal cause. Of course, that doesn't qualify for threatened abortion anymore. Exposure to toxins and lifestyle. It will talk about the lethality to the embryos. Venous and arterial thrombosis history will tell us that she's a case of APS. And previous lab or path or imaging, which will help us in diagnosing it easily. Examination ways, the patient is very stable vitally because the bleeding is not heavy in threatened abortion. Abdomen in most cases is not tender and it is soft. Fetal movements may be seen and FSH is heard in second trimester threatened abortions. No passage of tissue and the cervical os is always closed. You can do the most important investigation, either TVS or TAS in second trimester, to see a live fetus and see whether the os is open or closed. It also helps in ruling out retained products if it was an incomplete abortion. And ectopic pregnancy, very, very important. There also you can have bleeding and cramping. And molar pregnancy. This is very important because the definition clearly says a live viable fetus. The chronology of early scan is very important for us to understand, so that we have some patients, 35 days gestational sac is seen, 37 days yolk sac, 40 days fetal pole is seen, 42 days pulsations, and 63 days yolk sac should disappear. There can be a margin of 1 to 2 weeks extra time, but beyond that, you must be very clear that this pregnancy is not going to grow any further. Gestational sac plus 30 is a rough estimate of age in days. Crown rump length reliable between 9 to 13 weeks only. After that, better to go for BPD. Blighted ovum, by definition, 20 millimeter sac without a yolk sac, or 25 millimeter sac without a fetal pole, or a fetal pole without pulsations. So you have to have these things very clear in your mind so that you can counsel the patient instead of asking her to wait eternally. Fetal pole of 7 millimeter CRL should have pulsations. How to predict early failure, or how to predict that this pregnancy is not going to do well? If you see a smaller or a slow growing gestational sac that is less than 1 millimeter per day, when you did a scan at the interval of 1 or 2 weeks in the early pregnancy, you can say this pregnancy is not going to take off well. If you see a broken or a bigger yolk sac, which is more than 5 millimeters, then probably again, this pregnancy is not going to do well, because yolk sac is nothing like a tiffin box for the baby. Why will the yolk sac be big if the baby doesn't consume any food from that, right? So early oligohydramnios means a sac, gestational sac minus CRL. If it is less than 5 millimeters, it predicts early oligohydramnios, a poor sign for continuation of pregnancy. When you see the fetal heart rate, it is better to count also. If there is early fetal bradycardia, which is less than 90, then it's a bad sign. If the os is open in the first trimester more than 10 millimeters, it's bad sign. However, you don't go and put a stitch at this time. You wait till 13 to 14 weeks. Submucous or subchorionic hematoma, which is nothing but a first sign of incomplete placentation. There is impaired subsequent development of placenta because of that, and it is associated with oxidative stress, chronic inflammatory reaction in decidua, persistent myometrial activity. Also, there can be miscarriage, preeclampsia, abruption, preterm labor, and fetal distress and perinatal mortality. So subchorionic hematoma has to be followed up to see whether it regresses or stays same, or whether it actually increases. Other investigations, you have to do a RH factor, because whenever there is threatened abortion, you must, it's a sensitizing situation, so you must give a anti-D in a patient who is RH negative. Hemoglobin and hematocrit will tell us the amount of bleeding that is going on. Urine analysis and culture will tell us whether there is a problem of infection, which has to be treated, and the threatened abortion will go away. Other routine like TSH, GTT, VDRL, HIV, HbSAg have to be done. So finally, I come to the management, the most important part, which you must be waiting to listen to. When I have defined so clearly, all of you can know what is going to be coming up. So the management should be mainly expectant without any medical or surgical interventions. If the fetus is fine, there is no chromosomal anomaly, and there is no any uterine problems, that is like cervical incompetence, or if there is actually nothing you need to do, you have to just wait, things will settle down. If it was a low-lying placenta, it will eventually go up, so that there is nothing to be done. But having said that, no patient will be happy if you say nothing to be done. We have to see whether there is any problem that we can treat. Analgesia can be provided to help relieve the discomfort or cramping. Of course, you have to avoid NSAIDs, because that can itself be a problem. What is the treatment for karyotype abnormality? Can we really help? It is better we refer them to genetic counseling. They will tell which pregnancy can be continued, which pregnancy has to go for termination. They have a better way of dealing with those things. Prenatal genetic studies such as amniocentesis or coriolis sampling to confirm the type of anomaly, it will help us in actually prescribing MTP if the fetus is affected. Beyond that, you can't really help if there is a chromosomal abnormality. As far as autoimmune problems, the old concept was you can do immune stimulation by maternal transfusion with either paternal lymphocytes or pooled donor white blood cells, but this has got its problems, so it is no more prescribed. Same story goes with immunosuppression mechanism, where they prescribed steroids, that is prednisone, but it did not produce any noteworthy improvements. Rather, it created problems in the mother, so that is also out. What is to be done then? As I said, if the problem is that of immunomodulation, then we can help that by giving certain drugs, wherein we can help the immune system to shift towards Th2 type of reaction. Which are these immunomodulators? IVIG is one, but usually for a single threatened abortion, we don't give IVIG. Even in recurrent pregnancy losses, IVIG is very expensive, so it is hardly used. So what is a better and cheaper alternative? It is progesterone. It can be natural progesterone or injectable ones. natural micronized, which is oral and always widely accepted. But this also can be given in other methodologies like vaginal and synthetic, which is oral. As far as the treatment for APS is concerned, heparin plus aspirin has stood the test of time. A standard dose of 75 mg per day once you see the fetal pulsations, and you can continue it till you plan the delivery, up to at least 1 week till the delivery. The losses more than 10 weeks, that is enoxaparin 1 milligram per kg twice daily you can give. If loss is before 10 weeks, it is 1 milligram per kg once a day only. The mechanism of action, it prevents thrombosis, but more than that, it promotes trophoblastic invasion, inhibits trophoblastic apoptosis, it restores placental HCG production and alters cellular immune responses. So if you add immunomodulators, mainly progesterone, to this therapy, it is like Sone pe Suhaga, or it is adding icing on the cake. So what are these things? We have to, before that, I would like to talk one slide about HCQ treatment in cases where there is anti-nuclear antibodies. Many people believe in giving this HCQ 200 milligrams minimum 2 months prior and continuing up to 28 weeks. People also have given IVIG, but there's a strict absence of evidence for beneficial treatment. So results of phase 3 trial of HCQ for RPL is awaited. Till such time, I would rather withhold this drug. Same goes with HCQ with prednisolone also. Now, hormone abnormality, if there is hyperprolactinemia, you can give cabergoline or bromocriptine. Hypothyroidism, you can give thyroxine. HbA1c more than 6.5, strict control with pre and post conception. PCOS with insulin resistance, you can continue metformin, as I already said. So now I come to the last leg of my talk, the role of progesterone for threatened abortion. Now, this debate I have been hearing, reading for last 36 years, whether to give progesterone or not. Many researchers want to push away progesterone, but many other researchers try to bring it in from the side doors or the back doors. Now, this particular article says several trials have shown that progesterone supplementation does not improve outcomes for patients with threatened abortion. And progesterone is not currently recommended as treatment or prevention of patients with threatened abortion. Having said that, I know 99.9% of the obstetricians and gynecologists are giving progesterone knowingly, unknowingly, knowing the reason behind it or not knowing the reason behind it. So whatever it is, let me tell you what are the different types of progesterones that we have. Micronized progesterone, which can be oral, vaginal, intramuscular, and subcutaneous. Synthetic ones are dydrogesterone, oral, 17-alpha hydroxyprogesterone, intramuscular, and norgestrel and other norethistérone, oral, and others. Usually we don't give them in the pregnancy. Medroxyprogesterone acetate, again, we don't give them during pregnancy. Then, of course, there is drospirenone, again, not so popular in pregnancy. So finally, it comes to micronized natural and synthetic. No effect on the mood, no effect on HDL cholesterol, does not affect pregnancy outcome. Its side effects may cause fatigue and sedation, whereas synthetic ones will have all sorts of problems because any synthetic ones will have such kind of side effects. The formulations: oral, first liver pass effect with several biological active metabolites, high individual variability in plasma concentration. So vaginal is now become the most popular method of using the progesterone. Stable concentration in endometrium even when the serum levels are low, thus reducing the risk of systemic effects. Intramuscular is nowadays not very well preferred, but the advantage is that you can give once in a week. Supraphysiological concentrations, possible allergic reactions to be kept in mind. The benefits of micronization is bioavailability similar to that of other natural steroids, efficient oral delivery, particle size of less than 10 millimeter increases available surface area, suspension in oil and packaging in gelatin capsule has been shown to further enhance intestinal absorption, and micronized progesterone classified as category B drug, so it can be safely given. As far as LPD treatment concerned, you can give mid-luteal progesterone less than 10. The diagnosis is by mid-luteal progesterone less than 10 nanograms per ml. You can, when you induce, you can give CC plus HCG, luteal support with progesterone. Either it could be injection progesterone, or it could be oral micronized progesterone or dydrogesterone. As far as HCG for LPD is concerned, the rationale is it stimulates endogenous progesterone. So beneficial in women with recurrent pregnancy loss before pulsation appeared, with irregular cycles. It is not beneficial in women with Apla syndrome and chromosomal abnormalities, obviously. Now, this is the famous debate which has been going on. Maybe this is an old article, but this has clearly defined it. What is the difference between micronized progesterone and dydrogesterone? Now, there is micronized dydrogesterone also. In this study, they felt that when they gave micronized progesterone and dydrogesterone 30 milligrams per day, other one is 300 milligrams per day, similar rates of successful pregnancies, no difference in LFT. Then they pitched micronized progesterone versus dydrogesterone versus HCG. Here, they felt that no significant difference in clinical pregnancy rates. All said and done, studies on efficacy of progesterone are fewer, do not fulfill criteria for meaningful results because they are not prospective, exclusion of subjects with less than 3 losses and unknown causes, pre-stratification, randomization, all these are not possible. Hence, final word has not yet been set. Till then, let patients have benefit of doubt. Go ahead and prescribe progesterone of your choice, plus minus HCG. So anatomic corrections, of course, cerclage is the only thing in a proven case. Otherwise, putting empirical cerclage has no proven benefits. Infections, again, no proven rule unless it's a severe infection in the current pregnancy. So sum and substance of what I said so far is that threatened abortion is nothing but bleeding in the presence of live intrauterine pregnancy with closed os. Establish that pregnancy has no poor predictors for continuation by TVS in early pregnancy. Rule out chromosomal abnormalities by dual test and or genetic scanning. And if required, later amniocentesis. Perform TSH, GTT, prolactin to rule out endocrine abnormalities. If they are there, you have to correct them. Monitor cervical length, maybe only after 14 to 16 weeks. Pre-pregnancy folic acid can be given to control. Also, you have to control the endocrine disorders. IVIG and aspirin plus heparin helps in proven cases of APS only. However, it is difficult to diagnose APS during pregnancy. It is always diagnosed after the abortion, 12 weeks after to be precise. Progesterone and or HCG helps in proven cases of LPD, but the question mark is how to diagnose LPD properly. And also, they act as immunomodulators. Avoid coitus, physical and mental stress during pregnancy, especially if she has got bleeding. No role for steroid or other cocktail treatment. Some people give steroid, folic acid, progesterone, HCG, everything like a cocktail treatment. No role for HCQ yet till I would like to wait for that particular trial. TLC, whether it is tender loving care or therapeutic lifestyle changes, definitely helps. You have to administer anti-D in all cases of Rh negative women with threatened abortion. Anticipate preterm labor, FGR, HDP, APH, and PPH in all these cases. You may tide over 28 weeks, but you will have other problems after that. Thank you very much for your patient listening. Finally, I would like to end by saying affected couple often desperate for a solution sometimes grasp at unproven, useless remedies. What they need instead is a factual information, emotional support, and if possible, treatment based on medically established cause. Thank you.
Thank you, sir, for a wonderful, wonderful presentation and a very detailed and comprehensive talk on threatened abortion. You have covered each and every aspect of threatened abortion. So there are a few queries, sir. One is that in a over diabetic patient, if she has threatened abortion, would we like to give progesterone to her? How would it affect her sugar profile? And would we like to give her, or would we rather, because progesterone doesn't have a, again, it is empirically given. So, would you like to give her? What do you suggest, sir? This is one of my questions.
If we recall the basic physiology change in the pregnancy, the insulin resistance increases as the pregnancy advances, and it's basically due to steroid hormones that are produced during pregnancy, namely estrogen and progesterone, and that progesterone. So there is no point in giving progesterone in a patient who has already got high sugars. Rather, she requires probably the insulin sensitizers like metformin, and if it is not controlled with that, you can add insulin. I don't think progesterone has got any role in patients with high sugars.
Okay. High sugars with threatened abortion. So that was my
No,
query.
high sugars with threatened abortion, we have to be a little more careful because, as I said, generally speaking, the role of progesterone, as far as LPD is concerned, there is some role. And if the problem is due to an immunological issue where immunomodulation is supported by progesterone, other than that, it really doesn't have a real role. So if in the presence of high sugars, we can actually avoid giving progesterones for that patient and concentrate on controlling the sugars.
Yes, sir. Thank you, sir. Another query is that like in a patient with recurrent pregnancy loss, where we have not found the cause really, would we like our teaching is that we mostly supplement progesterone after the fetal cardiac activity is documented. So what would you suggest, sir? Should we start, because another teaching is that you should start her on supplementation as soon as she's pregnant. So what would you suggest, sir? Would we like to wait?
In fact, the
Cardiac
recent evidence says that if it is an unexplained recurrent pregnancy loss, I didn't touch upon that. I had 3-4 slides. I hide the slides for today because progesterone has got no role. Progesterone has got no role in unexplained recurrent pregnancy loss. In fact, after that PROMISE trial in 2016, one more trial came and said that there is a role for vaginal progesterone, but that paper had to be withdrawn, and they publicly withdrew that article. So I'm making it very clear, in unexplained RPL, there is no role for progesterone. So there is no question of whether to start it before pulsation or after pulsation. It has got no role.
Thank you, sir.
Yes, sir, but Manisha, I also want to say that commonly, generally, private practitioners, we don't wait for that cardiac activity or get the ultrasound done, and the soon suppose when the patient is only 5 weeks pregnant, we start giving progesterone and HCG.
Yeah, no, see, if the patient had conceived with infertility treatment, because sometimes even for recurrent pregnancy loss, though it is not a case of infertility, one of the options is induction of ovulation. One of the options is even IVF with donor egg. One of the options is even surrogacy. Though patient gets confused, patient will say, my problem is not infertility, my problem is recurrent pregnancy loss. But one of the options is, as you know, one of the causes for recurrent pregnancy loss is Robertsonian translocations and things like that, where donor egg has to be used. Or even the uterine anomaly is such that, or she may be having a problem with implantation, we may have to go for surrogacy. So in those patients, yes, definitely progesterone has to be started much before the pulsations are seen. Even in the luteal phase itself, it is started. Otherwise, in a first case of threatened abortion, if I have to restrict myself, empirically starting progesterone may not be necessary. It's not that progesterone is totally, let's say, how do I put it? It's safe. I'm not saying it's unsafe, but it is not totally out of any issues with the lady. Anything that can be avoided can be avoided.
Sir, excuse me, sir.
Yes, ma'am.
एक्चुअली ये देखा गया है कि जो थ्रेटेड अबॉर्शन या अनएक्सप्लेन इनफर्टिलिटी में यदि इफेक्टिव फॉलिकुलोजेनेसिस नहीं होती है एंड द क्वालिटी ऑफ द एग और द क्वालिटी causes one of the important cause of the threatened and the recurrent and the like the infertility also. So in those cases we are not waiting for the कि cardiac activity आए तब हम progesterone दे. We always, when the ovulation documented कि ovulation हो चुका है, तो we support even before the conception.
That's what I said.
Pregnancy is confirmed.
Yeah, that's what I said, ma'am. The luteal phase deficit starts in the follicular period itself. If the follicular genesis is not good, and when we know that, not only that, in all cases of ovulation induction, because there is some amount, in some amount of luteal lysis happens. So in those cases, there is absolutely no doubt that we blanketly support the luteal phase, where even implantation has not taken place, because especially if you are going for oocyte aspiration, there is some amount of luteal lysis happens because of the trauma or whatever it is. There is absolutely no doubt in that cases.
And the important role, sir, like the immunomodulation and the uterine quiescent, these things works a lot. So
definitely,
there is
I mean,
no
that's what I
harm to
said.
progesterone.
This debate, I have been actually, I was involved as a PG in this debate whether progesterone. Those days we used to debate about allyl and all those kind of things. And even it is 36 years now, the debate is on. Progesterone went out, came back, went out, came back. It came back as immunomodulator, if not as a hormone. So many things are happening. Even today, I am not saying that my word is the last word, because even after PROMISE trial, which clearly said progesterone has got no role, 2-3 trials came saying that progesterone has got a role, even in unexplained RPL. But then they were not well, what do you call? They were not well randomized. So unfortunately, those papers had to be withdrawn publicly.
Yes, sir.
Because what happens
Thank
is,
you, sir. It was
any research in an ongoing pregnancy, especially with progesterone, is a big challenge. You know, some people say you give up to 12 weeks, you give up to 28 weeks, and some people say you give throughout. So all the studies are not uniform. That's why even meta-analysis has been a big challenge. Systematic review is a challenge. And then there are so many varieties. Some people have used oral, some people have used vaginal, some people have used injectable. There's no uniformity. And prospective randomized study is a big challenge.
Sir, the second important जो controversy जो मुझे लगी कि like in the PCOS and in the diabetes, there is more chances of luteal phase defect. So we have to support, and only the answer is the progesterone. So sir, we cannot omit the progesterone even in the diabetes. Although we should be very observant, very keen to see key patient when we have to increase the metformin or we have to add the insulin. But for 3 months, for 12 weeks, most of the time we need to give the progesterone. We cannot omit it.
Okay.
Sorry, sir, I was not convinced with this your sentence, so that's why I added.
No problem. No problem. Of course, we are all here to discuss and share our views and learn from each other. There's absolutely no problem.
Thank you, sir. Thank you.
Sir, one more comment I would like to make, sir. We had done one study on the threatened abortion, the perinatal outcome. So we found that the incidence of indeterminate APH was high. Normally it is less than 1%.
Yes.
But in our study, we found to be around 2 to 2.5%.
Yes.
So this was one significant thing which I wanted to add.
Yes.
Another thing is regarding the predictive ability of the threatened abortion. Spiral artery Doppler done from 6 to 10 weeks of pregnancy. So we did one thesis just 2 years back, and we found that at 20 weeks, the patients who had threatened abortion at this gestation, about say around 22% were found that PI and RI were higher for such patients. So we can do spiral artery Doppler for such patients at around 6 to 8 weeks, especially for high risk patients, not all, but
Yes.
at least who are having recurrent pregnancy loss or
Yes.
are high risk patients like IVF patients or like who have hypertension, hypertensive diseases of pregnancy. Maybe in those
Yes.
it could be used, sir.
Yeah.
So
Yeah.
these
They
are
are all part of the spectrum, and
yeah.
it's really very nice to know that you
Hmm.
could prove that by doing a Doppler
Yes,
studies.
sir.
Yeah,
Yes, sir.
it's a well-known fact that when you do uterine artery pulsatility index and RI, they are high, especially when the placenta is unilateral. And these are the patients who can later develop some amount of threatened abortion, preterm labor, hypertensive disorder, FGR. Maybe they all belong to a similar vascular problems. So that is manifested in the early pregnancy as threatened abortion, later pregnancy as hypertensive disorders and FGRs and preterm labor. Yeah, there is a vascular problem, no doubt.
Thank you so much, sir, for the wonderful interactive session.
Yeah.
Any more queries, ma'am, if or we can wind up the session here and take on with the next speaker?
Sir,
Acha,
one more question from my side.
Yes, ma'am.
As you had said that we have to give anti-D in case of RH
Yes.
negative pregnancy in threatened
Yeah.
abortion. So if patient bleeds within a gap of 20 days, so she has second episode, then we
Yes.
need to repeat
Yeah,
it?
every 6 weeks you have to repeat. In another talk of mine on antenatal anti-D, I was telling that suppose the patient has bled once, you have given anti-D, and if she is actually stops bleeding and after 6 weeks it recurs, then you have to give second dose. Within 6 weeks, there is no need of giving second dose. Or if the same bleeding continues for more than 6 weeks, also you have to repeat. So it's usually after 6 weeks.
Okay. Do we
Because
need to
every exposure needs around 6 weeks of time to get rebuilding of the antibodies.
do her antibody titers?
If you have given anti-D, there is no need to do, because if you do, then the titer, it will show the antibodies. Whatever you have given, it will come as positive, and you are confused whether it is due to the injection that you have given or whether it is because she has developed the antibodies. So there is no need to do testing.
Thank you, sir. Thank you
Yeah.
so much.
Yeah.
Any questions? So next
sir,
in expert speak, we have with us an expert from Raipur, Dr. Asha Jain, ma'am. She will speak on role of progesterone in threatened abortion and what is her opinion about the role of progesterone.
No. Actually,
Just hold on, ma'am.
let Dr. Asha Jain speak, and because for this session, she is an expert with Dr. Muralidhar Pai talk, and she will give her expert comments also.
Thank you, Archana ma'am. Thank you, Dr. Rashmi. So, I'm not that much of an expert to give an expert comment over Dr. Muralidhar Pai's lecture. But as I'm a practicing fetal medicine person, namaskar, sir. Most great respect to you. And, because I practice fetal medicine and read a lot of fetal medicine papers, and when we talk about role of progesterone, so what we find is that the actual role of progesterone, other than what you have already spoken about, is in preventing preterm labor. If when you do an NT scan and you find that the cervix is short, then giving vaginal progesterone 400 milligram BD has a real effect equal to or more than that of cerclage. Cerclage is indicated only and only in previous histories. If there is a previous history of abortions, then you can go ahead and do a cerclage. But if it's the first case, then in that case, you need to give vaginal progesterone, or I have tried this dydrogesterone with equally good results. A cervix that is less than 2 centimeters. We talk of 2.5 centimeters, but actually less than 2 is the cutoff that they have taken. And if the cervix is less than 2, this really works wonders. So far, I have had a preterm labor in only one case who had a huge septate uterus. She had 3 previous abortions, and now she delivered at 29 weeks. But that is where the role of progesterone actually comes in. Otherwise, I agree with what Dr. Pai said, that we write progesterone mostly because we have to write something. I think it's, more to pacify us that yes, we've done something, rather than it doing real good to the patient, because the indications are very, very limited. So thank you. Thanks a lot for giving me this opportunity and hearing me out.
One very simple query. I think somebody may not feel free to ask is, should we write at 6 weeks or 5 weeks as threatened abortion? Just like we, whenever a patient comes with a history of spotting and we diagnose it as a threatened abortion.
Ma'am, I would do an ultrasound unless viability is confirmed. How do you write abortion?
That I
So
want to
first you need to confirm the viability. And once you have viability, there is a heartbeat, then you can write a threatened abortion. Pai sir, I think it was for you.
No, otherwise what will we write? What should one write clinically? Suppose a 5 weeks pregnancy with bleeding pregnancy, with bleeding, she comes with a history of bleeding. So what should we write?
Yeah, if you recall one of my slides, like as I agree with Dr. Asha ma'am, that whenever a patient has done a pregnancy test herself at home, or you have done the pregnancy test because she had a history of amenorrhea, the next immediate thing to be done is ultrasound. Okay. Now this ultrasound, as I said, by 35 days, you must see a gestational sac. Now, 37 days, you will see a yolk sac. 40 days, you will see a fetal pole. And 42 to 43 days, you will see a fetal pulsation. Now, your question is, now 42 days means 7 weeks, right? Before that, already 35 days is itself, you have seen a gestational sac. Now, once you see the gestational sac, unless you, as I put in another slide, a gestational sac without a fetal pore is called blighted ovum. And gestational sac with fetus without fetal pulsation is also called blighted ovum. So it is better to call it blighted ovum, just for a terminology. And once you see the fetal pulsation, thereafter, it qualifies to be called threatened abortion. So you may say it is a blighted ovum. If you see just a...
Yes, sir, I would like to add something. As long as you're not able to see a fetal pulse, she's saying 5 weeks. 5 weeks means it's only 35 days. You will see nothing at times. And people do abdominal scans. They see nothing. So it is better not to label it anything and call the patient after 10 days for a scan.
No, either
she will have a period.
No, I'll just add a little bit more. See, at 35 days, as you correctly said, it is almost 7 weeks. I mean, 5 weeks means it is 35 days. So if you don't see a gestational sac, which you are supposed to see, then she has got bleeding. You would call it pregnancy of unknown location, unless you see a gestational sac in the tube. I didn't elaborate on all those things. I didn't rope in so many things because this topic actually dwells on that as well. So at 35 days, patient comes, she is pregnant, 100% sure because she has done a pregnancy test, urine pregnancy test. So, but we have not seen a gestational sac also, what to call it. Now that is called pregnancy of unknown location. The next step is to do a beta HCG and then doubling time. So earlier criteria was 66% increase after 48 hours, but the new criteria is 33% increase is good enough to say that this pregnancy is likely to go towards uterus. But if the increase is not once in a week transvaginal sonography to see whether it is going towards ectopic pregnancy. So I hope I'm very clear. The chronology is like this. Patient has come at 5 weeks. She says, I am pregnant, but I am having bleeding. Do an ultrasound. I see a sac. Then, of course, she's pregnant. I would wait maybe another week or so, 6 weeks. She should see a fetal pole and pulsations. If I see pulsations, then I will call it threatened abortion. If I don't see pulsation, blighted ovum. But at 5 weeks, if I don't see even a sac, or 6 weeks also, if you don't see a sac, then I will simply brand it as pregnancy of unknown location. I hope Asha madam agrees with me. So there are 3 terminologies here: pregnancy of unknown location, blighted ovum, threatened abortion, in that order.
Sir, I would still add one more thing.
Okay.
And that is that unless you have a beta HCG more than 1500, you would not see a SAC even. So,
True. That is called discriminatory
in
zone.
that case,
Yes.
just a UPT would be positive at 30 microunits, right?
True.
So
True.
do a beta HCG first.
That's what I said.
And if it is beyond 1500, then
Yes.
do a scan, and
Yes.
then you will find out whether the pregnancy is, whether you can label it unknown location or not. Because
Yes.
if it is, you have a value of 300.
Yes.
You're not
Yes.
going to see anything.
Exactly.
The
So
first
that is,
thing to do is to do a beta HCG, followed according to the values, then proceed to a scan.
I agree. I agree totally. Yes. Because 1500 is considered as discriminatory zone. It may be too early that she has come. Sometimes, some of the books mention this. That is called implantation bleeding, or it's actually a misnomer. Maybe she is at that time supposed to have a bleeding, and she will have some amount of bleeding. Pregnancy is still finding its anchorage, and nothing is happening. She's too, she has come too early and things like that. So best is not to say anything, as Madam said. Okay, I'll refine or strategize steps, beta HCG, and then the ultrasound, then look for a sac, look for a fetus, look for pulsations.
Wow, that's
And
wonderful.
sir, do it transvaginally. Don't
Yes.
do an abdominal scan.
Yes, of course.
Good.
No doubt in that.
Because so many times the confusion starts right from there. The patient comes at 5 weeks and
They come very
somebody
early,
give.
and they are especially if they have been going through infertility, they are very anxious to conceive.
Anxious.
These things
And
happen.
so then they people giving HCGs also, and everything
Yes.
is so many times patient comes.
Yes.
Rule out
True.
ectopic. One thing is written, rule out ectopic pregnancy,
Yes.
but diagnosis they always keep as a threatened abortion.
Yes.
So this point is very clear now.
Yeah, very good.
Thank you, ma'am. Thank you,
Thank
sir.
you, Asha.
Thank you.
Thank you, Asha ma'am. So we have another expert, Dr. Vimlesh ma'am. She's a senior IVF consultant from Nandini Hospital. Ma'am, your overview about the progesterone and threatened abortion and
Actually, I am convinced with Dr. Muralidhar and Dr. Alka Jain. So I don't think
Alka Jain.
there's anything आशा जैन जी हाँ कि कुछ और ऐड किया जाए. So everything was covered very nicely, everything. But I always believe as the IVF, I'm doing the IVF, तो मैं प्रोजेस्टेरोन पर अच्छा बिलीव करती हूँ. Whenever there is compliance के ऊपर भी डिपेंड करता है कि प्रीफर वेजाइनल ही करते हैं. डाइड्रोजेस्टेरोन का बहुत अच्छा रिजल्ट है, लेकिन सम टाइम पेशेंट का कंप्लायंस अच्छा नहीं होता है वेजाइनल पर, तो हम लोग को ओरल डाइड्रोजेस्टेरोन पर जाना पड़ता है. अदरवाइज प्रोजेस्टेरोन के अलावा और कोई थेरेपी भी डॉक्यूमेंटेड नहीं है, प्रूवन नहीं है कि कुछ थ्रेटेंड अबॉर्शन में हेल्प करती हो, या रिकरेंट इम्प्लांटेशन फेलियर में, या रिकरेंट प्रेगनेंसी लॉस में कुछ और हेल्प करता हो. ऑल्दो इम्यूनोलॉजी बहुत डेवलप हो गई है, पर वहां तक पेशेंट कई बार नहीं पहुंच पाता है जब हम लोग छोटे शहर में प्रैक्टिस कर रहे होते हैं. तो वी हैव ओनली द आंसर ऑफ प्रोजेस्टेरोन एंड knowing the main reason of the threatened abortion or recurrent pregnancy loss. Like sir rightly said, जो सेप्टम है वो बहुत कॉमनली मिस हो जाता है, जिसकी वजह से मतलब एनाटॉमिकल कॉज, इट्स अ वेरी इंपॉर्टेंट कॉज जो मिस हो जाता है कॉमनली। तो सर ने बहुत ही अच्छा बताया है पूरा, तो मुझे लगता नहीं कि मैं उसमें कुछ ऐड कर पाऊंगी। थैंक यू सर, रियली इट वाज वेरी नाइस।
Thank you, really. It was wonderful. And at least मेरा तो concept clear हो गया ना. I'm really happy. Sir, we present to you this award. Please kindly accept it.
Thank you so much, ma'am. Thank you so much. It's really a pleasure always to interact with you all, even though it is online. So nice to learn.
We have these awards ready for the chairperson, Dr. Manisha Gupta, Dr. Asha Jain, our expert today. Dr.
So you
Vimlesh
please,
Sharma, our
Asha and
expert.
Vimlesh, you please accept. We very humbly present to you this
Thank you,
award,
madam.
and thank you for
We are
coming.
really honored.
Thank
Thank you. Thank you, ma'am.
थैंक यू मनीषा, यू आर वंडरफुल। और तुमने बहुत स्पाइरल आर्टरीज वाला जो अल्ट्रासाउंड का व्यू ऐड किया, इट वाज नाइस थे।
That was really good.
Actually, sir, we did a thesis just last year. The student passed out last year.
Very nice.
I
Very
thought
nice.
I'll just mention.
वेरी नाइस, वेरी नाइस।
यूजुअली हम
डॉक्टर मुरली सर, ये डॉक्टर मनीषा, she is very humble person and doing wonderful work, and she at present she is
Yeah,
head
I
of the
can make
department.
out. Madam is HOD, but she is, so humble.
Thank you, sir.
डॉक्टर मनीषा,
सर गाजियाबाद आइए, आपको
All
वो
of you, please
ये
come to
विमलेश।
Sikkim. It's a wonderful place if you have not seen already.
Yes, sir, we will all come, and sir, you do please do come to Ghaziabad and Hapur, and Vimlesh will show take you to a very great. There's a Britishers वाला time का स्टड फॉर्म है वहाँ पर विमलेश के अंडर में।
Okay.
so it is
It will be nice.
एरिया है, कैंट एरिया है, वहां पर एशिया के मोस्ट ऑफ द जो वो डंकीज वगैरह जो म्यूल है वो सप्लाई होते हैं।
अच्छा
तो
अच्छा अच्छा।
तो इट इज ए सर लगभग मोर देन 1 CR के जो वो है
ओह
वगैरह। तो it is a
wow. ओह too good.
And sir, वो बहुत पुराना ना, it is highly well maintained place.
Oh yeah,
One must go and see.
I will definitely come sometime.
अर्चना जी, सर को
Ma'am.
गाजियाबाद बुला लीजिए। आई वाज ट्राइंग फ्रॉम लास्ट 1 year और समहाउ प्रोग्राम बन ही नहीं पाता। सर आप
Yeah.
डॉक्टर
Manisha
Agarwal
Agarwal.
Yes ma'am, yes ma'am, I know. I was almost came once, but then
Manisha is our dynamic secretary of Ghaziabad.
I know, but if I was in Manipal, it would have been easier to come. Sikkim
सर
is
लास्ट 1 year से आई एम प्लानिंग बट समहाउ प्रोग्राम।
Yes,
So
ma'am.
when you are in Delhi,
Yeah, sure.
in or
I will
around
definitely.
Delhi,
I will definitely.
Yes, sir. Whenever you come, you let us know, and
Sure.
our this
we'll
Ghaziabad
make
team will
special
take you.
program for you, sir.
Definitely.
So one yes sir, one really we will take you there, and वहाँ बहुत royal buggy वग्गी है बहुत, and that is especially Vimlesh Sharma का मतलब
Sure.
upper hand है वहाँ पर।
most welcome and definitely you will enjoy. Definitely
Thank
you
you.
will.
Of course. I will look forward to.
Okay, sir.
Okay, ma'am.
Thank
Good
you,
night.
sir. Thank
Have a
you.
great
Thank you so much, sir.
Okay. Rashmi,
And-
now you carry on.
Our next speaker is dynamic and young Dr. Paridhi Garg, and she is MBBS MS, and she's right now academic head and associate professor in Rama Medical College, Hospital and Research Center. She'll talk on post-abortal psychological crisis. Dr. Paridhi.
Thank you, ma'am, for your kind words. So, good evening, everyone. Myself, Dr. Paridhi. First of all, I would like to extend a warm regard to all my seniors and thank Dr. Archana for such a nice opportunity to talk me on a heartfelt topic of post-abortion psychological crisis. After having an elaborative talk on threatened abortion, we'll try our level best to manage the patient and treat her well. But in case the patient is not able to have a successful pregnancy and she gets into abortion or she miscarries, then what? Abortion mental health is one of the most important but yet unheard domain amongst us as gynecologists. In our daily practice, we deal with women undergoing miscarriage either as an induced abortion or miscarrying. We treat them, but do we cure them? So we'll begin with our talk with the same topic. Miscarriage is actually a difficult and distressing life event for a female. Post-abortion stress syndrome is the residual pain of abortion, which is felt through the feelings of grief, anger, shame, guilt, or other mental or physical turmoil. Many people experience anxiety, anger, abandonment, or a sense of loss and may feel less able to cope following an abortion. And these feelings can even continue for months or even years afterwards. They can even progress to depression. So, the symptoms which are described as post-abortion syndrome are similar to post-traumatic stress disorder, but unfortunately, we as medical professionals and mental health experts at times fail to recognize the painful aftermath of abortion as an actual condition, making it difficult to be felt, heard, or understood. The symptoms vary from the discussed above to a wide range of symptoms. In 2008, American Psychological Association Task Force on Mental Health and Abortion concluded that it is clear women do experience sadness, grief, feeling of loss following termination of pregnancy, and some experience clinically significant disorders, including depression and anxiety. So, if we look at the experts, there is now virtually no disagreement amongst researchers that some women experience negative psychological reactions post abortion. But still, there are several concerns of disagreement on grounds of what is the prevalence of these experiences or reactions, what is the severity of these reactions, the definition of what a public health or mental health problem will constitute as, and the classification of these reactions. Talking about the impacts of abortion, the impacts of abortion on a female life could be on grounds of socioeconomic, the emotional aspect, or the psychological aspect. Studies do not indicate a linear relationship between abortion and its consequences, but there is a great variation in terms of socioeconomic and demographic variables of abortion in care seeking women and whether their abortion was performed legally or illegally. As in India, we can see a lot many people or a lot many women undergo abortion illegally as well. So, if we look at the patients, in many cases, we can say that abortion at times is a positive coping mechanism, especially when it is performed in the first trimester of pregnancy. Again, in view of the female, in a better aspect of the female, so it could be a positive emotional reaction. But there are opponents of abortion who say that it has a negative emotional psychological consequences as abortion. And these psychological consequences, if seen, they depend on the quality of life of the patient, what kind of a family life she is having, the number of children she has, whether the pregnancy terminated was a planned one or an unplanned one. Then there are cultural or regional beliefs of the patients and at times the genetics also. Research consistently has shown that experiences are highly variable, individualized, and often characterized by both positive and negative feeling. So, it is not like that every woman undergoing an abortion will experience stress, but some women may have a moderately stressful, while others may experience a severely stressful event after abortion. So, who are these women, or how would we identify these women who would experience severe stress? The American Psychological Association has identified some common reasons that having an abortion can lead to depression. These can include a perceived stigma or lack of social support. There could be a history of prior mental health problems. The personality traits of patients, such as low self esteem or low coping skills. there could be features of the pregnancy, whether the patient wanted this pregnancy or she did not want that pregnancy. So the American Psychological Association Task Force has laid down various risk factors for the same. Apart from these risk factors, there could be a perceived pressure from the family or partner, or at times opposition from the family or partner, or terminating a pregnancy that a patient actually wanted. It is found to be a predictor of post-abortion distress. Research has also shown that a woman who experiences doubt during abortion decision making, she is in a midway whether she wants to abort. At times, it is the career at stake. She wants a pregnancy, but maybe she wants it later. It came out as an unplanned pregnancy. So, in such situations, there are poorer mental health outcomes after abortion. Uh, at times, women may have a poor self-efficacy or a poor self-coping skill. So, in such cases, also there is a poor post-abortion outcome. In case a patient has any history of physical or sexual abuse, or there is some external disorder such as conduct disorder or alcohol abuse, this may also increase the vulnerability of a woman undergoing abortion to post-abortion traumatic disorders. So, now we can talk about one of the most propagated disorders, prior history of mental health problems. If we look at the previous researches, this is one of the most commonly studied disorder or a risk factor. And there are two schools of opinion running. Some would say that prior mental health is actually a cause of post-abortion mental disorder, while some say that it is not. The stress vulnerability models assert that pathogenic effects of stressors are more pronounced in vulnerable persons, and psychiatric history is considered to be a vulnerability factor of major importance. So, in case a patient has a history of mental disorder, it is more likely that she will experience more stress around the abortion, which might increase the likelihood or timing of recurrence of the disorder. In particularly, when her mental health problems are associated with increased level of stress. Now, as I already said that there are two schools of opinion going on about the prior mental health as a cause of post-abortion stress syndrome. So is it reasonable to attribute all the negative effects of abortion to pre-existing factors? On an average, it is seen that a woman with history of abortion has a higher rate of mental illness as compared to a patient who has never undergone an abortion. Or you can say that if the patient has a mental illness, she is more likely to go for an abortion. So it is said that a higher percentage of aborting women, or the women who go for induced abortion, basically we are talking about, they are already emotionally broken to begin with. So there are higher rates of mental illness of abortion of mental health following abortion is rather just a continuation of the pre-existing maternal frailty. Now, the two school of thoughts that we are talking about, the AMH proponents and minimalist. As per the studies, the AMH proponents say that a woman, if she has a poor prior mental health, it is more likely that she became pregnant in problematic situations, or she is more vulnerable to the external pressure or manipulations to undergo an abortion, or she has a weakened coping skill. So, in such a situation, if a patient gets pregnant and she has to undergo an abortion, she will take this abortion as a potential stressor. So, a patient having a history of prior traumatic event will take this abortion as another traumatic event and experience post-traumatic stress disorder or post-abortion psychological crisis. While the bunch of people who are AMH or abortion mental health minimalist, they say that a patient who has a poor prior mental health, she is more inclined towards abortion because she feels that if she delivers and raises an unplanned child, it will be bad for her. So she opts for abortion. So according to the minimalists, they say that post-abortion stress disorder is basically just a continuation of the pre-existing mental health rather than a direct and independent cause of mental illness. Next, we come on to the question. The majority of the people will ask me, so do we really need to assess the mental health related to abortion since it is just a continuation of the prior mental health issue of the patient? So while abortion may relieve some stresses, it is seen that it may also create new ones. It is seen as a new stressful event of the patient. So there is need for better pre-abortion screening. Though as of in India, we are not facing many litigations, but in case a physician fails to screen for known risk factors such as prior mental illness before recommending or performing an abortion, he or she can be guilty of negligence if the woman suffers any subsequent mental health problems. So, how should we manage this? Once we have assessed the mental health in a patient seeking abortion or undergoing miscarriage, and we identify a concern regarding abortion mental health, how should we further proceed? We all know that time is the best healer, but in many cases, post-abortion symptoms don't simply fade over time, but they can persist for long periods of time. We all would say that in such a situation, the best key is counseling and support. Yes, we have to go for effective counseling. We have to identify and address broader emotional and physical health and other needs and concerns of the women. We have to solicit and affirm women's feeling and provide emotional support. We have to have appropriate answers to the questions or information on medical conditions. Why does she have an abortion in case it is a miscarriage? And what are the test results? What is the treatment? And especially the pain management. Pain can also be a stress for the patient post-abortion and lead to post-abortion stress syndrome. Also, we have to clarify their thoughts about pregnancy. When a patient has a miscarriage, apart from the current miscarriage, her major concern is about the future pregnancy, whether she will have a normal pregnancy or she might have fertility or infertility. So we have to clarify their thoughts about this. We have to tell them the cause. We have to tell them the treatment. When would she resume ovulation and her reproductive health future? Apart from this, we have to understand and respond to other needs and concerns that would potentially impact their care. For example, in infections with HIV or STI, especially when there is an abortion, in cases of the survivors of sexual or gender-based violence. And also, we have to address any other concerns that a woman may actually have. So, now, next thing is, what should we not do? By now, many of us would agree that abortion, either as a miscarriage or termination of fetus, produces any kind of consequence which could be physical, social, psychological, and it may last for a long period of time and affect the family, personal, or social life of an individual. Now, at times, even as medical practitioners, we get judgmental and go for preaching instead of treating. A few would also propagate that giving birth may produce mental health benefits. We tell the patient that bearing children may actually contribute to mental health improvements through direct biological effect by expanding and strengthening the interpersonal relationship with the children and others, or by behavioral adaptations that may replace risk-taking with self-improving behavior. This is a commonly seen thing that is done in clinics when a patient approaches us for a medical abortion or an induced abortion. But in spite of the fact that abortion can lead to mental health disorders, there are studies that emotional problems resulting for abortion are rare, especially those which are the induced abortion and abortions which are done with proper decision. There are pros of abortion which rely on studies which indicate that the emotional responses to legally induced abortion are largely positive. So it is emphasized by most of the studies in the last 2 decades that if an abortion is done, it's an induced abortion, it is relatively benign procedure in terms of the emotional effect, except when pre-abortion emotional problems are existing or a patient has a prior mental health disorder. So we should avoid giving any statement to the patient when a patient approaches us for induced abortion. So it is seen that mental health effects associated with abortion are minimal and within the expected range for women seeking abortion, but these effects are significant enough to justify more research and better screening and counseling in order to reduce the number of adverse outcomes. So each and every patient which is found at risk of post-abortion stress syndrome or psychological crisis should be screened and counseled beforehand. And we should avoid any negative counseling to an abortion seeking woman. Abortion is the right of the female, and we should help out, reach to her, support her to make an informed decision about her pregnancy and about herself. So, to conclude, I would like to say that it is true that some women may have significant mental health issues that are caused, triggered, aggravated, or complicated by their abortion experience. In many cases, there could be a feeling pressured into abortion or choosing an abortion without sufficient attention to maternal desires or moral beliefs. But there is also common ground that the risk factors identifying women who are at greater risk, including a history of prior mental health, can be used to identify women who are at risk of post-abortion psychological crisis, and these are the patients who may benefit from pre-abortion and post-abortion counseling. Next most important thing is that the request for unplanned pregnancy is an evidence that there is a lack of knowledge of contraception or a failure to use an effective method or failure of the methods. So there is a need for the good family planning, which can reduce the number of unplanned pregnancies and the abortion rates, and thus the cases of post-abortion psychological crisis. With this, I would end my slide with the take-home message that there should be better screening for risk factors, which would help to identify women who may benefit for additional pre and post-abortion counseling, and may also help to prevent cases of women being pressured into unwanted abortions. In addition, complete insight may help mental health counselors to be more aware and sensitive and provide the counseling services that women want and need. Thank you.
Thank you so much, Dr. Paridhi, for such an elaborate talk. Basically, we need to give TLC, tender loving care, to the post-abortal patients. Thank you so much, Paridhi.
Thank you, ma'am.
With this, now we'll wrap our session.
Thank you, ma'am. Thank you so much for giving me this opportunity. And thank you for such a sweet token of appreciation.
Okay, party bhi milegi. Acha,
She
one
could
thing,
join. She
I
could
want to say
join, but
in our time, we used to say that this pregnancy is precious and that pregnancy is precious. I know one thing, it is very difficult to be a woman and very difficult to tackle the pain of abortion. So these two things are really, really very something, and abortion, post-abortion care is very important to make them comfortable, to feel them
even a
comfortable.
woman going for induced abortion for career stake, I think, is a woman's choice. And she's already into an emotional turmoil.
Yeah.
उसके ऊपर already मैम family का pressure होता है, family वाले already
तो
उसे
मैं
मना
कह
कर
रही
रहे होते हैं,
हूँ,
then she seeks our care
Yeah.
and we also say कि क्यों करा रही है तू termination
क्यों
continue
करा
कर दे, तो वो और
नहीं,
ज्यादा
फिर भी
मैम
whatever
और वो
reason,
नेगेटिव फीलिंग्स आई थिंक नहीं जाती होगी उस पेशेंट की, शी इज ऑलमोस्ट इन अ ट्रॉमा, मतलब ये इंड्यूस्ड अबॉर्शन के साथ है। और जो मैम मिसकैरी कर जाते हैं उनका पेन तो मे बी हम लोग इजीली, बट इंड्यूस्ड अबॉर्शन नहीं समझते मैम।
Yes, now, but it is really, it is our duty to make them feel very comfortable and give them hope. if we are able to give them hope, it is something very good. And with time, you very rightly say, with time is the best healer. But it's still very somehow slowly and slowly. The one thing which always new day, new hope, new pregnancy, so that nothing will be the same. Everything
Yes.
changes after one incident. One incident
My
changes
first
everybody's
slide,
mind.
my first slide said, ma'am, that I have to carry a fake smile every day because a woman who aborted her child is not allowed to be sad. तो हम उसका वो पेन देखते ही नहीं है, वो she is smiling, she has undergone an abortion, but we don't see behind that smile what all she is going through. And as physicians, this is the time we should see behind that smile also. And being women, we should feel that.
Precious, yes. Very, very precious. So something, even then I always say I hate tears, but somehow some tears are good. And कहते हैं ना, बहने दो अभी तो so there is a one time the smile is important. Sometimes tears are also important, and we have to give hope. That is something very important as a gynecologist, as a healer. So we should take care. Very nice presentation, Paridhi, as expected from you. I think everybody will enjoy, and let our expert, if present, let them also say a few words. Dr. Vimlesh or Dr. Asha?
डॉक्टर परिधि, your talk is excellent. बहुत ही अच्छा तुमने बोला है. And this is a very important point कि always planning should be there before conception, and even जैसे है ना कि even before marriage counseling is there. तो इसी तरीके से उसी स्टेप में फैमिली प्लानिंग काउंसलिंग शुड बी देयर कि यदि कंसेप्शन होता है कब तुम प्लान करोगे, तो प्लानिंग प्रॉपर शुड बी देयर एंड द काउंसलिंग शुड बी प्रॉपरली देयर. यदि लेडी पहले से ही प्रिपेयर्ड होगी तो हो सकता है उतना साइकोलॉजिकल स्ट्रेस, उतना साइकोलॉजिकल ना हो यदि वो मेंटली प्रिपेयर्ड है. एंड द सेकेंड इम्पोर्टेंट थिंग, द एनवायरमेंट अराउंड हर, चाहे वो घर का हो, चाहे ऑफिस का हो, चाहे बाहर का. सबसे बड़ी बात जो तुमने बड़ी अच्छी पॉइंट आउट करी थी, द नेगेटिव एनवायरमेंट अराउंड हर, चाहे वो फैमिली का हस्बैंड कहता है बच्चा चाहिए, फैमिली का सारा नेगेटिव लोड, सब चीज. तो दीज पॉइंट्स आर वेरी इंपॉर्टेंट. तो लेडी हैज द राइट व्हेन शी वांट टू कंसीव, व्हेन शी कंटिन्यू इट. तो ये बहुत इंपॉर्टेंट पॉइंट है. यदि प्लानिंग के साथ प्रेगनेंसी होगी तो आई थिंक जो पोस्ट अबॉर्शन ट्रॉमा है वो कम होगा. That is very
Definitely, ma'am.
Ma'am, may I say something?
Yes. You are highly required to say something.
Ma'am, actually, I will go against what everybody is saying.
नहीं, अभी तो मैं यही कह रही हूँ ना, आपका तो नाम ही आशा है और हमें पेशेंट को आशा ही देनी है.
मैम, मैं वही कह रही हूँ, जो सब कह रहे हैं मैं उसके अगेंस्ट जाऊंगी. आज का जो कल्चर है वो कल्चर, people want to get married or they want to be in live-ins, they want to enjoy, they don't want to get children. And then suddenly at the age of 40 they realize कि अब तो pregnancy हो नहीं रही है, अब हमको pregnancy चाहिए है. So the thing is, when we are counseling them, I agree totally to the empathy part. We should be empathic. We should understand what is happening to her. But as consultants, as gynecologists, we should explain everything to the woman. That, you know, whatever people who come to abortion for you may be 35 years old and she's been married 6 years and she's come for her first pregnancy abortion. Everything is happening. It's not always a young girl who's in the pressure of her mother-in-law or family. No, not necessary. So, you know, these things cannot be generalized. I would just say, always empathize with your patient. Try to understand why she's taking any kind of decision. But we also need to make them aware of medical facts. You're 35. You're aborting this pregnancy, you might have a difficulty in conceiving again. You might have a problem later. So medical facts have to be transmitted by a gynecologist under empathy, you cannot just be going on for abortions. I had a woman who had 9
Yes, there
abortions.
is one thing, Asha. I think our main talk was regarding this missed abortions or threatened
No,
abortions
if
or
it is
returned
missed,
abortions.
but what Dr. Paridhi spoke about was that it's induced abortion and the woman has that mental trauma and everything.
She said by the way she took that part because she has to complete the
No,
talk.
otherwise if it is
mainly
a
our
threatened
concern
abortion,
was that.
again, I think we as doctors should be very clear about the facts to her, that it's not your fault, it's nobody's fault. That conceptus is not healthy and it's being lost. And you can try again. So I think we as gynecologists should be giving the actual scientific facts first in a very empathic manner. That is what I feel. Sorry,
Yes,
Dr. Paridhi.
Ma'am, I agree with you. Ma'am, I totally agree with you. Even in my clinic, I am counseling the patient to continue. I always call them twice that you go think over this overnight and come back to me tomorrow. If you still think that you want to go for an abortion, I'll prescribe it to you. But think overnight on my say. I always do that. But we have to understand the patient situation. She at times comes thinking over it for 2 weeks and unnecessarily putting her into a negative feeling कि तुम्हें infertility हो जाएगी, तुम्हें ये हो जाएगा, तुम क्यों abort कर रही हो? At times patient abortion pills लेके आती है मुझसे, तुमने अपने आप से ऐसे ही खा ली, तुम्हें लगता नहीं है तुम्हें बच्चा चाहिए. So these are the things which I wanted to say that we should
What I said,
avoid in clinic.
empathy should be there. We
Yes, ma'am.
have to
We have to tell
empathize
them the
with the
fact.
patient, but we have to convey the scientific facts, even if they are unpleasant, even if they are
And
not correct.
yes, ma'am. And when we have
That
to,
is
we
for
cannot
sure.
generalize these things. As you said that a patient is having 35 years of age, we should have a different way of dealing with her. And if a patient is in her early 20s, then she has a good life to go on. She can go with it. She's a graduate student. Or she got married in family pressure. Then there is a different way to deal with that patient. So it cannot be generalized, but we have to be empathetic and we have to convey the facts in a manner that she doesn't undergo that mental trauma because of our words.
That is true. Agree. That was really good.
Right, but the
you.
important is counseling. Counseling should be must. क्योंकि किस एज में वो शादी कर रही है, कैरियर ओरिएंटेड भी होती है, so many factors are there. तो we should make them aware कि भाई यदि तुम इस एज में मतलब उनके सुनना है, पहले उनका सुनना है, then we have to say the positive and the negative points about the abortion and about the continuing the fertility. So important thing is
our talk was mainly the psychological. Our talk was about the psychological trauma of the patient after abortion. So that we were talking about that. And thank you, experts, and thank you, Paridhi, and thank you, Deepika. Thank you so much.
For our chief guest and chief convener.
Oh,
Dr.
we were waiting for Kawita Bapat till the last, but I think she was traveling and not able to join. Anyway, she will be there with us in the next one.
Our chief convener, Dr. Archana Verma, ma'am, thank you so very much for continuing with this expert speak series and choosing Jagsonpal as your partner, academic partner.
I salute to all women present here and the men Muralidhar Pai talking about the threatened abortion and Jagsonpal as usual.
Jagsonpal being the truly progestin people, we have natural micronized progesterone as the Divagest range. We have sustained release tablet 200 and 300 mg. We have vaginal soft gels Divagest 200 mg. Then we have injection progesterone as Divagest 100 mg. We have Divatrone 100 mg, 10 mg of micronized dydrogesterone, 17 hydroxyprogesterone caproate as maintained 250 and 500 mg injections, allylistanol 5 mg as maintained tablet, also norethistrone acetate, cyclorec CR10 and plain cyclorec 5 mg. Then we have Dynogest tablet 2 mg as endorec for endometriosis. Truly the progestin people. So we hope to see you again and again. Thank you so very much for being with us today.